I hope I find you all well from wherever you are around the world. My name is Mr. Chitumba once again. Today we are going to discuss on scrotal ultrasound. Scrotal ultrasound is one of the basic sonographic examination that you're supposed to know, that you're supposed to do on a daily basis. Why should you know the basics of scrotal ultrasound scan? Because an injury to the testicle can be irreversible and it can cause infertility. So if you are able to do a basic ultrasound scan, you can salvage the testicle before it dies. So in this module, we are basically going to talk about the anatomy, the technique, and the pathology that affect the scrotum. So before I elaborate further, just like any other examination that you do, basically you're supposed to scan your scrotum in two planes. That is the longitudinal section and the transverse section. However, prosthetic anatomy is a little bit different from the basic anatomy and histology that you do when you're doing your medical degrees. Because certain things that are learned in histology, in embryology, in basic anatomy, they are not visualized in our daily practice in ultrasound. So you have to limit yourself to anatomy that you can visualize. So that's the anatomy that I'm going to capture here, and then we'll build it from there. So basically these are the planes that you're supposed to look your testicle. They are the longitudinal and the transverse. But you don't limit yourself to the longitudinal and the transverse sections. So you have to even angulate the probe, use various angles to visualize anatomy or to hunt for anatomy that might be hidden somehow. Like the other structures, the tail of the epididymis, for instance, the epididymis itself, the head itself, at times when you just use the basic longitudinal and transverse, you might miss it. So, just like any other examination, you're supposed to know the type of equipment that you're supposed to use to do your scrotal ultrasound scan. The curvilinear probe is the basic probe. A high resolution probe is the best probe when you're doing your scrotal ultrasound scan. Why? Because the testicles are superficial structures, so they are better visualized using a high frequency transducer. Depending on where you work and the type of transducer that you have, you can use any linear array transducer that you have at your disposal that can demonstrate the testicle to advantage. The higher the frequency, the merrier. But as you know that the higher the frequency, it comes at a price. The higher the frequency, the higher the attenuation of the beam, meaning to say that you can't penetrate deeper structures. So if we have got other pathologies like hydrocele, when there are bigger masses in the scrotum, you will not make much of the scrotum. So you have to use or revert back to a curvilinear probe. So the best position for a scrotal ultrasound scan is when you use two towels. So the first towel is here. You're also giving patient dignity. You have to cover the penis, and also the other towel that you put below the testicles or the scrotum, like this. So this is the best position when you're doing your scrotal ultrasound scan. So the same image here. So as I said before, like any other structure, the standard way of doing an ultrasound scan of the prostate and of the scrotum, is the longitudinal and the transverse section. So you can move your probe the left, the right, just like that in transverse plane. If you want to visualize the left scrotum, hemiscrotum, you push it this side. If you want to visualize better the right hemiscrotum, you move it further to that side. So again, in transverse plane, you can move the probe caudally or cranially. Cranial, caudally, just like that, up and down. So I'm going to discuss on the basic testicular anatomy. The basic anatomy that I'm talking about is anatomy that is not all-encompassing. We need sonography specific anatomy that you can visualize yourself on ultrasound scan. So that's the superior aspect, that's the inferior aspect, that's the anterior aspect, and then the posterior aspect. Then we have got our testicle here, just posterior and superior, and then towards the inferior aspect, that's where you find your epididymis. So the epididymis basically has got the head, the body, and the tail, as you can see from this image. So this is just a basic image that is capturing the basic anatomy in a scrotum. You must also know that the scrotum is suspended outside the body because there is an optimum temperature below body temperature where sperm production is ideal. So if the testicles retract into the abdomen where the temperatures are so high, it can become a problem again in terms of those temperatures. They can denature the protein sperm, and then it dies, and also an individual might be infertile. So these are just the testicles side by side, right testicle, left testicle. So whenever you're doing your ultrasound scan of the scrotum, make sure that you also compare or you visualize your images so that you can compare the echo texture, even the perfusion of the right vis-a-vis the left testicle. So in this image captured here, again, is the basic anatomy. So you can see this is our testicle here. In between the testicle here, there is a space that contains free fluid. We call this the tunica vaginalis cavity or space. And then what we have here, that's our scrotal sac, that's the scrotum there. Then there is a layer of peritoneum here that we find here is called the visceral peritoneum, and then the visceral peritoneum here is called the tunica vaginalis. We have got another tunica vaginalis that thinly lines the testicle like this, the thinly lines it. Then the space in between the tunics is what we call the tunica vaginalis cavity. It is in this cavity where you find most pathologies in a testicle, like hydrocele. So free fluid, you can see free fluid around the testicle here, then we call that hydrocele. You can also see blood here in case of trauma. You can also see pus collecting here in case of pyoceles. So this is a very critical space that you must always make sure that you analyze so that you don't miss critical pathology. Also, you must also know that in this space, in this potential space, there is also some free fluid which are mild for lubrication purposes, so they are more physiological in nature than pathological. So inside the testicle, that's where you find what are called the seminiferous tubules, which are responsible for the production of your sperm inside there. And then there is a septa which divide the seminal vesicles like that. and then we've got this space where the septa meet. This is the rete testis, which confers also stability to the different or the variable seminal vesicles that we have there. But this anatomy, as I said before, is very difficult for you without any pathological entity to visualize the seminiferous tuberose on ultrasound scan. So the epididymis, as I said, is more posterior, and it goes to the superior and the inferior aspect of the testicle. You can also visualize it here, and then I'm going to show you the seminal, the spermatic cord, sorry. So basically what we have here is the anatomy again. So you can see the bladder here, and then just below the bladder, inferior to the bladder, that's where you have got our prostate, and then we have got our testicle there. We have got the epididymis there, and then we have got the vas deferens there that collects sperm all the way, and then it meets the ejaculatory duct here, and it goes to meet the urethra that side. So you must know this basic anatomy. This is the basic anatomy that you're supposed to appreciate, because when you're doing your sonar, you basically see this basic anatomy, and then you can also relate to the pathology that you're seeing. So as I highlighted before, it is very prudent that you must see also the two testicles side by side, so that you can compare the echogenicities. Like here you can see here what we have, the brighter portion here, that's the mediastinum of the testicle, the mediastinum of the testicle again, right and the left, and then you can see the blood perfusion or the blood flow here in the testicles. So it's almost comparable. So in case where there is hyperperfusion, when the testicles are side by side, it's very easier for you to see that there is a pathological entity, or there is a testicle that is hyperperfused, that is hypoperfused, when you are comparing to the next. So dualization is it's a good practice when you want to do structures which are dualized, like the testicles. So again, the measurement of the testicle is also very critical. You are supposed to know that the testicular volume, or the size of the testicle, can also have a bearing in terms of the pathology. So you can have people with very small testicles. We call that testicular hypoplasia. So they might also experience infertility because of the small balls which they have, or the small testicles which they have. You can also find someone with an enlarged testicle due to trauma or some other pathologies. So it's also very prudent that you measure the testicle in two planes. And then the volume for those machines with presets for the scrotum, automatically if you measure, it gives you the volume. But if there's no preset, you can use the correction factor of 0.5 to multiply by the volume that you get from the two dimensions. So let's now go into the pathologies which affect the scrotum. When you're dealing with these pathologies, I need you to know the distinction between anatomy that you know and sonographic anatomy. So if you relate things from the perspective of sonographic anatomy, your life becomes very easier. So let's come here. This is our testicle there, and what we have here, that's the scrotum. That's our scrotum there. And then you can see in between the testicle and the scrotum, there's free fluid there. So when there is free fluid that is clear like this, we call that hydrocele. So this is hydrocele. And you can also see that there's another lesion there that is appearing like a mass. This is also a mass, yes, but this is the epididymis. That's the head of the epididymis, very prominent like that. So you must not confuse this for a pathology. So there is free fluid here, and then you can see the normal epididymis there, and this is the scrotum there. So if you want to measure the thickness of the scrotum, you can see it from this side to that side. The scrotum itself can also be inflamed, so it's very critical for you to take note of the thickness of the scrotum. So this is simple hydrocele. There are times during which the hydrocele can be infected or can be inflamed. Like in this case, you can see this is not clear anechoic hydrocele. There is internal echoes that you are seeing inside there. At the same time, you can see there is septations inside the hydrocele. So this is complex hydrocele. So you can find complex hydrocele in cases where there's an infection and then there's pus that is going in, or there might be blood bleeding into the tunica vaginalis cavity. So there are different types of nomenclature again for a hydrocele. There is hydrocele which is confined to the scrotum, like I showed you in the previous images, but there is also hydrocele that extend all the way into the inguinal canal. So this type of hydrocele that you see extending all the way into the inguinal canal is called a communicating hydrocele. So mostly this type of a hydrocele is noted in newborns, and it can also affect the elderly. So when there is no septum here dividing the scrotum and the inguinal canal, we call that communicating hydrocele. There is a septum here, or a muscle that is supposed to be here, or a tissue that is supposed to be here, that's supposed to divide the scrotum with the inguinal canal, which is called the processus vaginalis. So the absence of the processus vaginalis, or incompetence or perforation, or when the processus vaginalis doesn't close, it causes communication. The major demerit of communicating hydrocele is when you want to do this type of a sauna and you compress the scrotum, this fluid there will move towards the inguinal canal and it goes into the peritoneum, and then you might feel that there's nothing here. And also when the patient is lying, because of gravity, this fluid can just go back into the peritoneum and it appears like the hydrocele is resolved. So this you have to take note whenever you see hydrocele. Check if it is confined hydrocele or it's hydrocele that is communicating. Again, in this instance, you can see here is your floating testicle there, and you can see this hydrocele is simple because it's clear, it's anechoic, but it's communicating, it's going all the way here towards the inguinal canal. So this is a case again of communicating hydrocele. As I said, you can see internal echoes, different levels, low level, middle level, or it can be high level internal echoes that you can visualize inside the tunica vaginalis cavity, like in this case. So this is a sonographic appearance of what is called infected hydrocele. So when you have got infected hydrocele like this, if you compress a little bit, you can see these internal echoes, they will start to move. So when these internal echoes are moving, we call this acoustic streaming, or some they call it snowfall appearance. So it appears like the snow that is falling. So they will be moving, they'll be whirling around like that. So this is infected hydrocele. So after infection, when an abscess rupture or when pus collects, it can form this, or give us this type of a configuration. So again, this is the anatomy. You must know the distinction between the scrotum, the transition to the tunica vaginalis, and also to the testicle. So you can see here there are small tubular structures which are anechoic here, like that. They appear serpiginous like that inside the testes. So this is what we call tubular ectasia of the rete testes. So if you see such, it could be when the rete testes are blocked somewhere, then you can see the tubular ectasia of the rete testes occurring. So you can see this, they are very tiny like this, like that, and they are not affecting the whole testicle. So this is called tubular ectasia of the rete testes. Don't confuse tubular ectasia of the rete testes with tubular ectasia of the epididymis. So the epididymal tubes also can have the same configuration. It's also called ectasia. Someone can have coexistence of both a tubular ectasia of the rete testes and tubular or ductal ectasia of the epididymis. So now you can see coexistence of the two. Here what we have here, that's tubular ectasia of the rete testes, and you can see here the whole length of the epididymis is also having the dilated tubules here, which are very tiny like that, giving a serpiginous structure. This is in keeping with tubular ectasia of the epididymis. You must also know the anatomy that you rarely see, or some they don't know. The testicle itself has got a remnant, a small appendage here that we have like that. So this one becomes more prominent when there is a hydrocele. So a hydrocele delineates a testicular appendage better. So you can visualize an appendage of the testicle or like this when there is a hydrocele. So this appendage is of no clinical relevance, but at times it can twist and then undergo torsion. When such happens, it can cause severe or excruciating pain. You can also see reactive hydrocele around the testicle. So if you put color Doppler, when there is torsion, you don't see flow on the appendage or the appendix of the testicle. When it's torsion, you can see it becomes like this. It's edematous, enlarged, and then no color flow. So this is the configuration that takes place in the acute stages. But the chronicity, or with time, because there's no flow or there's no blood that is feeding the appendage, it atrophies. When it atrophies, then it shrinks, it dies, and it can calcify. So know that the appendix of the testicle can also undergo torsion. So now, the epididymis itself can be inflamed in isolation. So you can see an intact scrotum, intact testicle, but an inflamed epididymis. So when the epididymis is inflamed, it's called epididymitis. So epididymitis can be acute or it can be chronic. So in acute phase stages or in early stages, the epididymis, it gets edematous, it gets thickened. When you put color flow, you see increased flow on Doppler, on power Doppler. That is called hyperemia, increased blood flow. So when there is hyperemia, at the same time there's also tenderness, and you see an edematous testicle. We must always think about acute epididymitis. In chronic stages, just like what I said for your towards the appendage of the testicle, it shrinks, it undergoes necrosis, and at the same time it can calcify, or sclerosis can take place, and if it dies, it means there will not be flow as well. So there can also be a combination of an inflammation of the epididymis and the testicle itself. So that condition is now called epididymo-orchitis, meaning to say both are inflamed. But when the testicle only is inflamed and then the epididymis is spared, we call that orchitis only. So if you put color Doppler, you can see this hyperperfusion affecting both the testicle and the epididymis. This is in keeping with epididymo-orchitis. So you can't talk of an inflammatory process when there's no pain. So basically, an inflammatory process, it comes with pain. At the same time, you can also see inflammatory exudate, or you can, in the scrotum, it presents as a hydrocele. We can see fluid around here that is in keeping with a reactive hydrocele. The other thing that's normally affect the elderly, the bowels can prolapse via the inguinal canal, and then they can find their way into the scrotum or the hemscrotum. So if you say bowel movement inside the scrotum or in the inguinal canal, you must also know or make a diagnosis of bowel inguinal or inguinoscrotal hernia, or both. So you can see here, that's a bowel there, and it's prolapsing in the inguinal space, just like that. So this is bowel hernia, inguinal hernia. At times, omentum of fat can also prolapse via the inguinal canal. When such happen, we can call that omental hernia prolapsing also into the inguinal canal, and it also can affect the scrotum. So why is it that we are so concerned about learning these different types of pathologies? It is because when you hold your probe, you are hunting for an abnormality. So you can't hunt for an abnormality. You can't be a hunter who is going to the jungle to hunt without knowing what you want, How are you going to identify this is the type of animal which I'm looking for? I must kill this type of an animal. This is a baboon, it's not eaten. So you have to make a distinction between a hyena, a cheetah, a zebra, and then you can have a range of animals that you say, these I can eat. So that's what a skillful hunter has to do. So again, you can see the bowels there, and they are compressing the testicle here. So if you put your probe here, you can see peristalsis in real time there, in keeping with a bowel motion. So you can see bowels inside the scrotum itself. So this is a bowel hernia. So as I said already, that orchitis is simply an inflammation of the testicles. So if the testicles are inflamed, you call that orchitis. So it can also exist in isolation. When all other organs are looking intact, then you can see hyperperfusion of the testicle. It becomes edematous. It can become hypoechoic in early stages because of the exudate. Then you can also see a reactive hydrocele. It will be tender on some palpation. So that's orchitis. Orchitis is an inflammatory process. So if you know the basic sonographic appearance of an inflammatory process, you are covered. You also have to know that in chronic stages, the testicle, it shrinks in size, it becomes small. Then that is due to lack of oxygen, and then it dies, atrophies, or it undergoes sclerosis. The other notorious culprit that you might come across when you're doing an ultrasound scan of the testicle is you might come across an abscess. So when there's an inflammation of the testicle or there's orchitis, the abscess can actually form inside the parenchyma of the test itself, and you can see an abscess. An abscess, mostly it will be hypoechoic, and you can see free fluid inside. At the same time, you can see peripheral vascularity. The abscess itself doesn't have color flow because it's representing infected tissue or tissue that is undergoing a necrosis. So that's the sonographic appearance of an abscess. So it's organized like this. It can liquefy. That's what an abscess appears like. Okay. So again, when there's an inflammation, there can also be an abscess that can develop extra-testicular outside the testicle, and then you can see the fishnet appearance like this. This is in keeping with a pyocele. So there's no intra-lesional perfusion in the pyocele. You can see peripheral perfusion there, but there's a thin line between a pyocele and a hematocele. They can look the same. They can also have the same reticular pattern, and then you can confuse the two. But basically, a pyocele is an inflammatory process. So if you put color Doppler, you expect to see hyperperfusion, especially on the peripheral aspect. But hydrocele, hematocele, it's due to a bleeding. So bleeding, it can also, when it's chronic, when it's acute, it can also cause hyperperfusion during the first stages, but in most instances there might not be any perfusion around the rim or the capsule of the hematocele itself. But the history now is very pertinent in terms of differentiating a pyocele from a hydrocele. So basically, a hematocele, it occurs following a trauma or with a history of trauma, and then pyocele with a history of inflammation when the patient just comes to the department saying, I don't know where the pain is coming from, I just started to feel the pain. So that can be an inflammation which is non-traumatic in origin. So again, you can see there's a thin line between the pyocele and the hematocele that you are having here. So the hematocele can also have the fishnet appearance that you see here. At the same time, active bleeding, when the blood is bleeding, you can see low level internal echoes here in the tunica vaginalis cavity, and you can see that the testicle is fractured somewhere out here. You can see that there's a hypoechoic area there. So this is a hematocele. So you can see the testicle here that it has been traumatized, and then you can see the swollen just like that. So the history is very pertinent for you at times to distinguish a hematocele with a pyocele. So again, you can see the low level, this is the middle level internal echoes there, which can also be suggestive of a hematocele depending on the history of the patient. So testicular fracture is another common pathology that you can come across in any age groups, especially among sportsmen or those people who are into sport. So they can injure the testicles by different ways or different means when they are playing their sports. So you can see these hypoechoic regions or areas here. You can, in the first place, mistake this one for artifacts, but if you bring the probe from different angles, and also if you do it in two planes, you can visualize that they still remain there just like that. So this is an example of a fractured testicle, and you also have to marry this to the history, because a testicle cannot just fracture without any sign of trauma, because it's also protected. So now you can see here that this testicle is lost Its architecture is an architectural deformation that you are seeing here, and then there's fluid here also with internal echoes. So this architectural distortion is due to testicular rupture. So basically, this is the same anatomy which I've captured before, but when there's a torsion, you can see that the spermatic cord there, it coils like that, and then the front part can go to the back, and the back part can go to the front of the testicle. So torsion is basically a twisting of the testicle. So when twisting occurs like this, it kinks the blood vessels, and when they kink the blood vessels, it means the testicle will not have blood supply, and it will not have oxygen and nutrition. Then it can die. So this is a typical case of a testicle that is dead. That's a captive testicle. So after 6 hours and beyond, when there is a torsion, the testicle start to die. So you can see, if you put color here, you will not see a color flow. So this is a classical case of testicular torsion. The testicle is twisted. So if someone kicks your balls, they can twist, or when you're sleeping and you can compress them, or when you wear tight fitting pants, they can also be susceptible to torsion. So you can see that in chronic stages, you can see the testicle is dying, and then it's undergoing necrosis there, and then you can see infarcts on the testicle. If you put color flow, you don't see flow. So this is the sonographic appearance of testicular torsion. So torsion is also a bit confusing, especially if it's not 360 testicular torsion, because you can see segmental sparing of blood supply. So if such happens, when you compare the two, you can relate the history and the pain that the patient is going to be complaining with the reduced blood flow on that ipsilateral side, and then you can also infer that someone might be having an inflammation, testicular torsion. So we are going to discuss on testicular torsion, testicular cancer after the torsion. Yes. So testicular cancer is a little bit different from thyroid cancer, from breast cancer. Why? Because breast cancer and thyroid cancer, they are more standardized. Like the screening for those is more standardized, using the BIRAD and the TIRADS. But also the testicular screening for cancer is also been somehow or somewhat is being standardized. So there's what is called the TNM system that is being adopted by some department, but it's not yet universal. So for now, I would want you to stick to the tradition of suspecting a testicular cancer without giving this classification, which is not yet standardized, because the referring clinician will have a confusion on what you're talking about when you talk about the TNM grading system of testicular cancer. So I need you to just know how to make a description of a lesion that is suspicious of testicular cancer. But the gold standard is, whenever you see an intratesticular lesion or mass, you have to query malignancy, unless you are convinced that it's an abscess, unless you are convinced that it's a simple cyst. Otherwise, you have to query malignancy. Then biopsy will do the rest. So the staging for testicular tumors is performed according to the TN system with the staging groupings. It can be remembered in its abbreviation forms as. So this is the summarized version of testicular cancer staging. So stage 1, confirm the testicle and epididymis and spermatic cord and the scrotum. So if you see a lesion that is confined within the scrotum without sending mess to another lesions that can call it stage 1. Then stage 2, lymph nodes involved but not distant metastases and serum tumor markers are not very high. So basically, if you see the involvement of lymph nodes and then accompanied by a testicular lesion, you must also query stage 2 of testicular cancer. But when you now at stage 3, it will send distant metastasis to distant organs like the liver, the spleen, and then also you can sense a nose. Then that will be basic stage 3 of testicular cancer. So make it a point that whenever you are dealing with testicular ultrasound scan, make an extra effort to look for distant signs if you suspect that there can be cancer of the testicles. So the major testicular cancer types, there are basically 2 major types, which is the seminoma and the non-seminoma germ cell tumors. But I'm not going to delve more into these because it's not the gold standard for ultrasound scan to distinguish a seminoma from a non-seminoma nematomatous tumor. But non-seminomatous tumor, they are rapidly growing lesions, so they can invade the surrounding tissues faster, and they can also go send meds elsewhere. So you can see these are multiple lesions, irregular in outline. But seminomas, they are slow growing, they can be regular in outline, and then without meds, and they are not as rapid, they are not as aggressive as your non-seminomatous tumors. So that is what all I can say pertaining to these types of cancers. But biopsy will do the rest. Otherwise, if we are going to be overzealous trying to do microscopy using ultrasound, you have problems. So here is a classical example of a seminoma. You can see that is an isolated lesion there, and it's just affecting this portion or this segment of the testicle. The rest of the testicle is more intact beside the microcalcification that we are having there. So this is a typical example of a seminoma. So it's not aggressive and it's more localized. You can also see here, this is also a seminoma, but that is liquefied. So you can see it's only affecting this portion and sparing this segment of the testicle there. So this is more of a seminoma. So you can see this other type of a lesion is calcified, it's ill-defined, it's irregular as you can see, and it's sending acoustic shadows that you can see here. So this is an example of a non-seminomatous germ cell tumor. You can see that it's irregular, and also since it's intratesticular, I said if you see tumors intratesticular, you must always query malignancy. So your role that I want you to give more emphasis on is to be able to identify the location or localize lesions. Are they intratesticular or is extra-testicular? So when that is done, it will be easier for you to know that most extratesticular lesions, they are benign, and most intratesticular lesions, they are mostly malignant or cancerous. So that's the golden rule that you must adopt. Then biopsy can then make a distinction. You can also see these calcifications inside the scrotum or in the tunica vaginalis space, and then that will be called the scrotoliths. So these are just stones. They can also develop there, just like what they do inside the gallbladder, the urinary bladder, for instance. So again now, you can see this type of a cancer, this is a lymphoma, is more aggressive. So you can see multiple nodules like that, and it's also hyperperfused. So this is a lymphoma. So it's a non-seminomatous type of a tumor. because of the aggressive nature that it is having. Like that, you can see it's developing like that. Okay. So extra testicular masses, you can see masses that you find in the extra testicular region. You have to describe them. At the same time, most of them, they'll be benign. So it's up to you to capture that also in your report, that this is an extra testicular lesion. It's regular in outline, it's well outlined, it's slightly hypoechoic as compared to the testicle. Is suggestive of it could be benign lesion. Then you give it back to the referring clinician. They will decide what they want. So this is just a metastatic lesion that is non-cancerous, but it's being sent from a cancerous lesion elsewhere in extratesticular. So there is this other interesting lesion that you can see. You can find this inside the testicle or outside the testicle. So this type of a lesion that appears like a disc or with the onion peel appearance like that, this is called an epidermoidal cyst. So an epidermoidal cyst is always benign, whether you find it in the intratesticular space or in the extra testicular space, it remains benign, but it was got a different or a unique configuration appearing like a disc with the onion peel appearing like that. So if you see anything like this, you must know that this is a epidermoidal cyst. So again, this is an intratesticular epidermoidal cyst. You can see how it appears like a bullet that is piercing like that. This is an epidermoidal, though it is intratesticular, but it's a benign lesion. So again, there are times during which you can see this night starry appearance with these tiny echoes here inside the testicle. So this is what is called testicular microlithiasis. So testicular microlithiasis can also take place following an episode of an inflammation that is chronic. So with chronic inflammation, basically you can find a microlithiasis taking place. So some scholars, they say that if you find them in the same testicle, you find 5 or more microcalcifications like that. That's why when you call it a microlithiasis. But if they are less than 5, you just call them microcalcifications, and then you don't call it testicular microlithiasis. There can be other causes as well besides inflammation, so they can just happen. But when sonar, you can't tell the exact cause of the microcalcifications besides seeing them and documenting them like that. Also, when you're doing a scrotal ultrasound scan, you can also see a simple cyst. So this simple cyst can be anywhere. If you see a simple cyst intratesticular like this, this is just a simple cyst like another. You just have to document like that. You can also see it in the epididymis. You call that the epididymal head cyst. Then you have to just document like a simple cyst. It can also cause pain because it's a mass, it's a space occupying lesion as well. So you can see here is an epidermoidal head cyst. It's a clear anechoic. It's containing clear anechoic fluid here. If you see internal echoes inside there, then it ceases to be an epididymal head cyst. Then you can call that a spermatocele. So a spermatocele, basically it has internal echoes inside like that. So they say if there's a blockage here of the vas deferens, then sperm can be retained. It accumulates like that to form what is called a spermatocele. So a spermatocele and an epidermoidal cyst, they are different because the spermatocele contains internal echoes of sperm, and then an epididymal head cyst contains clear anechoic fluid. Okay, so this is another example of an extratesticular tumor. Here you can see here it can be found in the epididymis. So these lesions, which are regular in outline, they can be what are called adenomatoid tumors, which are benign extra testicular tissue. They can also happen or occur inside the testicle, but you need to have a biopsy to differentiate a malignant transformation from this adenomatoid benign lesion. So again, there are times during which the scrotum itself is the one that is inflamed, and when the scrotum itself is inflamed, you can see that it is thickened like that, it's edematous and thickened, and it will be tender on sonopalpation. If you put color, you can see here there is a flow that is going in the raphe or in between the two testicles like this. This is called the fountain sign. So if you see the fountain sign with thick edematous scrotum, you must know that that is called acute scrotum. So inflammation of the scrotum is called acute scrotum. So it's a pathology on its own. So it's a standalone pathology. You can find acute scrotum minus orchitis, minus epididymitis, or minus epididymo-orchitis. So it can be a standalone pathology that you have to also take note of. So there is this other condition that mostly affect the newborns, or they can be born, then the testicles are not felt. So that is called undistended testicles, or it's called cryptorchidism. So now doing a sonar with people who having cryptorchidism, you must be so much aggressive in terms of checking the abdomen, the inguinal canal, for the scrotum. If you don't see it, because they can be overlaid by bowel, so you might not see the testicles, you have to recommend an MRI so that they check for the balls, because if they remain inside for quite some time, they can turn cancerous. So undescended testicle is one of the common conditions that you can find, especially in kids or in those people whom it was ignored when they were growing. So you can find the testicles having descended. So the problem of undescended testicles, it can also cause infertility. Okay. The other thing that I didn't mention when I was talking about the ductal ectasia is you can also find obstruction of the paminiform plexus, or the veins of that drains the testicles, and when that happens, they become engorged, or they become dilated. The caliber of the vessel veins increases, and then that is called varicoses. So you can also find varicoses in the paminiform plexus due to the blockage of the veins, or incompetence of the valves. So the disadvantage or the demerits of varicose veins, if they persist like that, they can also be one of the causes of infertility. So make sure that you capture those things as well when you're doing a sonar. So again, the spermatic cord itself can also get inflamed. Unfortunately, the spermatic cord is one of those areas, or one of those things which are not so easy to visualize when there's no ascites or free fluid in the scrotum or in the inguinal region. So, but if you put color, or with someone who's presenting with the pain around the scrotum, if you put color going up in the inguinal region, you can actually see hyperperfusion, and you can see the edema here. So when that happens, this is an inflamed spermatic cord, saying we call that funiculus spermaticus or funiculitis. So this is inflammation of the spermatic cord. So you also have to take note that it's not only the epididymis and the scrotum and the testicles which get inflamed. The cord itself can also be inflamed, a condition which is called funiculus spermaticus. Okay, there is this other major pitfall that we come across. Most radiographers, sonographers, they think that when they see this, then the testicle is fractured. No, this is not a fracture. It's called a two-tone testicle due to what is called the transmediastinal artery, because the artery carries blood. So if you see blood there, you might think that it's the hypoechoic line, or the ecopenic line is due to the tear of the testicle, of which is just the artery. So how do you make sure that this is not a tear? You put color, then the transmediastinal artery, it feels nicely like this. So this is a confirmation that this is not a fracture site. The last aspect that I want to discuss with you before you go to your respective departments and try to implement whatever I am discussing with you now is what is called polyorchidism. So polyorchidism is not a pathology per se. It's just a condition whereby someone is born with more than 2 testicles. So they can have 3 testicles, 4 testicles, just a congenital abnormality. So you can see here 1, 2, 3. So you can confuse the 3 testicles, the other testicles for masses. So check the echo texture, and also mostly people presenting with these their incidental findings, and they don't present with any symptoms or pain. So this is polyorchidism. So you must also take note that when you hold your probe, that you might encounter more than 2 testicles, which is in an abnormal normal variant of the testicles. I think I have said more than is necessary. I have said more than is enough. It is up to you guys from the eastern part of Africa, from the southern part of Africa, from the western part of southern of Africa. You have to do your role. The role is for you to try to implement a little bit. If you learn a pathology per day, your practice will never be the same again. I thank you all for your time. Let's meet again in the next module. Thank you so much. Be blessed.